Hello, and thank you for participating in this session, Coronary Diseases and Acute Coronary Syndromes Case Posters. I will share with you a case report describing rare consequences of SARS-CoV-2 infection on coronary arteries. I have no disclosures. Spontaneous coronary artery dissection is a rare coronary event mostly associated with autoimmune and inflammatory conditions. We share a case report of a patient admitted to the Creighton University Medical Center Bergen Mercy campus in Omaha, Nebraska, with a clinical presentation and diagnostics suggestive of spontaneous coronary artery dissection after COVID-19. She was a 43-year-old Caucasian female with a history of obesity and atrial fibrillation during pregnancy. She was brought to the hospital after she had a syncopal episode due to ventricular fibrillation, leading to cardiac arrest, requiring defibrillation on site. Prior to the episode, she felt fatigued during the day and skipped dinner due to lack of appetite. Importantly, she had been tested positive for COVID-19 by PCR with mild symptoms about 12 weeks prior to the episode, and she recovered within a week after self-quarantine at home. On initial evaluation in the ER, she had atrial fibrillation with rapid ventricular response, hypothermia, decreased breath sounds bilaterally, had non-tender abdomen, equal blood sounds, and pleural edema without any cyanosis. The patient required endotracheal intubation for airway protection. Initial labs revealed normal CBC, elevated CRP of 71.2. Initial troponin I was elevated to 2.55 nanogram per ml with a peak of 21 nanogram per ml. Venous lactate was elevated to 14.2 millimole per liter. Her SARS-CoV-2 RT-PCR was negative, but she had positive SARS-CoV-2 antibody test depicting prior COVID-19 infection. Subsequently, the patient progressed to refractory cardiogenic shock necessitating 4 vasopressor agents. A transthoracic echocardiogram revealed a left ventricular ejection fraction of 20% with new onset global hypokinesis and global myocardial wall thickness. A left heart catheterization revealed spontaneous coronary artery dissection in the left circumflex artery. An Impella device was placed for cardiovascular support initially, but she ultimately required VA ECMO. She was also given pulse dose IV methylprednisolone, given the suspicion for myocarditis as a late inflammatory manifestation of COVID-19. She was able to be decannulated from VA ECMO after about 30 hours of therapy. Ultimately, she was managed conservatively without coronary intervention. The follow-up transthoracic echocardiogram 1 week later showed improvement in her left ventricular ejection fraction to 60%. We'll talk more about spontaneous coronary artery dissection as a rare sequela of COVID-19. It is important to highlight that spontaneous coronary artery dissection should be kept in the differential diagnosis in patients who have acute COVID-19 or prior COVID-19 within past 2 to 12 weeks and noted to have symptoms of acute coronary syndrome or new onset cardiac arrhythmias. So far, there have been very few reported cases of spontaneous coronary artery dissection and SARS-CoV-2 infection. However, all of them have a variable clinical course. Our case had findings of spontaneous coronary artery dissection about 12 weeks after COVID-19. Overall, spontaneous coronary artery dissection is an underreported coronary event and has a prevalence of around 4%, mostly associated with autoimmune and inflammatory diseases. Various mechanisms of spontaneous coronary artery dissection have been proposed, including endothelial dysfunction and intraplaque hemorrhage leading to intraadventitial hematoma. Various mechanisms of spontaneous coronary artery dissection have been proposed, including endothelial dysfunction and intraplaque hemorrhage leading to intraadventitial hematoma, followed by longitudinal spread along the coronary artery and eventually dissection of tunicate. Although spontaneous coronary artery dissection can be due to other contributory factors in critical illness, however, the association of this pathology with COVID-19 needs to be further elaborated. It is important to highlight that COVID-19 may lead to various cardiovascular disorders ranging from acute coronary syndrome to spontaneous coronary artery dissection, and various management protocols for this pathology need further research. Thank you.